So it's my pleasure to introduce our panelists of just top-level thinkers and also really great friends. We've got Doctors Damian Gatnell, Susan Jacob, Marguerite McDonald, Roberto Pineda, and Vance Thompson. And I'm going to have Dan kick off our panel discussion.
Yeah, that's a great session. A couple of things that will change the way that we're practicing would be something like the presbyopia drops. How does that fit within our practice? So I was going to kind of bring that one up and see how people think this is going to happen. Is that going to increase the people that are interested in refractive surgery? Where do you see it fits in it? Maybe Damien, you could start out and other people could chime in.
Well, it's very interesting technology. I would say that there are two different approaches. To me, making the pupil smaller is probably the oldest way to address presbyopia, and people who were on Pilo in the past spontaneously experience an increase in the near. On the other hand, the technology which softens the lens is very exciting because it offers a completely new paradigm and could also have implications for cataract apparition in the future. So I look forward to those lens softening molecules, maybe more than the meiotic ones.
Yeah. Vance, maybe how would this affect your overall market, your referring doctors and everything else, if we had a drop for presbyopia? Is that something that's going to enhance our market?
Yeah, I think I get excited about it because I think it's going to increase awareness in presbyopia. You know how you help someone 20 years ago and then they think their LASIK wore off because their lens got stiff. I think it's going to be neat for them to just know what's going on behind their pupil. So that'll help with patient education. And I think it'll also get them in the pipeline earlier to think about future presbyopic treatments once the drops aren't working so much, whether it be next stage monovision, next stage lens replacement. And I think it'll be a great area for optometry and ophthalmology to work together on this presbyopia issue. So I think it's a wonderful next stage for us.
Marguerite, what are your thoughts on this?
I think presbyopia drops will bring more people to refractive surgery. If you look historically, the marketing experts tell us that patients like to try a temporary solution, then they move on to a permanent one. A lot of people will wear a toupee and then move on to hair transplants, or padded brassieres and they move on to breast implants. And there's a long history of people trying a temporary solution, they like it, but they want something permanent. So I think it'll increase the number of refractive surgeries.
Beautiful. I'm going to shift gears a little bit and ask Susan, you pioneered the use of human tissue, corneal tissue, for presbyopia therapies and also for Intacs-like treatments. Maybe you could just share with the audience what your experience has been like and how is this changing your practice pattern, going from the innovative state but to actual treating your everyday presbyope and or keratoconic.
Right. So thanks, George, first for inviting me here, Dan, you too, and Marconi. I think allogenics is really the way to go forward. It's become a very exciting field where there's a lot of things happening simultaneously. We started off with the Pearl inlay, which is presbyopic allogenic refractive lenticle around 2014-15. We had good results with it. But presbyopia is a field where when you go surgically, there's always a little bit of give and take. So you do sometimes have a little bit of decrease in the distance vision of the inlay eye along with the gain in the near vision. But what I found even more exciting is its use in keratoconus, because that's really fantastic. You have this ability to completely reshape the cornea, get your topography improved, everything perfect, and at the same time get rid of all the disadvantages that are associated with synthetic implants. So just recently I did a case where we had also, not only in addition to the treatment of keratoconus as such, but also a case of Intacs, post-Intacs melt, where I removed the Intact segment and put in this care segment instead. And that was really, really very satisfying because the topography remained the same, the vision remained the same, but we got rid of that problem for the patient. So for keratoconus, I really feel it's a great way to go forwards.
I think that this is the whole idea of working with our eye banks and working with tissue on being able to develop some of the refractive error. And I think topography adjusted lenticle for keratoconus just makes all the sense in the world, and I think that we'll all be seeing a lot of that developing coming on.
Right. And just to add to that, we've also been able to very successfully implement it in our clinical practice because we've got a lot of patients. We've done more than 120 patients of cares now, which really makes it very satisfying because patients come back for their second eye, they refer their friends, and so on and so forth.
That's great. One thing that we saw in this, especially with John Canalopoulos' 15 years experience with topography-guided ablation, but there's a lot of difference, especially with people around the world, on how often are they using topography-guided ablation. Is it only for rescue procedures where we know that we can do some help, or is it starting to switch to somewhere we're going to have our primary procedures be topography-guided? So what's kind of the input that people are feeling? Roberto?
Well, I mean, I certainly have been using the topo-guided treatments for several years now, and I've been very impressed with, as John pointed out, with the results. I think even for primary treatments, patients, you know, the FDA studies showed that they have much higher, better refractive error in the end. So I definitely think it's technology that's in development. It's been refined thanks to work by Dr. Canalopoulos, but I think we're going to see more of this through the different laser platforms, and is definitely a way that we should all be looking to help improve outcomes for our patients.
Vance?
Yeah, I agree with Roberto, and I think that one of the most intimidating things about doing topo-guided is understanding a topography modified refraction. And when you sit there and compare it to what you've been used to, and you see this different level of cylinder from 0.5 to 1.5, you have a decision to make. And one of the beautiful things has been the improvements in the software. With what Dr. Canalopoulos has done, with what Dr. Lobanoff is doing with the Forcides software, has really actually made it a lot easier for us to actually decide what the treatment plan should be. So now it's growing in our practice.
Yeah, I would agree. I think the Forcides for the U.S. market, I know it was just released at ESCRS in Paris, as well as going to be a big step forward for a lot of refractive surgeons who may have been a little tentative about using this technology in the past.
Yeah, the Forcides softwares, we've had some great feedback and early experience in the U.S. I'm really excited about being able to standardize something that's been somewhat elusive and nuanced. Dr. Gatnell, I'd just like to get some closing thoughts on how are you utilizing, kind of in daily practice, wavefront optimized versus topography guided in France?
Well, in France, we have no such limitation, so we can really choose whatever we feel more appropriate for a specific eye. And for the topographic guided indications, I would, of course, select patients with more irregular astigmatism than those who have a perfect regular cornea, for which we know that wavefront optimized works quite well. The problem being, though, that if you have an irregular cornea, it may be a sign of underlying disease like keratoconus. So again, sometimes we orient the patient toward topography-guided PRK, and in this domain, addressing the epithelial properties and the way the epithelium may mask or smooth out after surgery, the underlying irregularity is a very open field, I think, for the future. So it will be probably addressing the shape of the cornea and also the way the cornea heals after the surgery, so we can have an even better approach in these eyes.
Perfect. And we have a minute for a virtual discussion, actually, where we have real-time questions coming in, and we have our virtual monitor, Dr. Mallow, who's going to respond.
No, just a question about fills in about your experience. Since you don't have limitations, Dr. Gatnell, what are your experiences or thoughts in hyperopic topographic guided treatments?
Well, in hyperopia, it's very interesting. I think, as been said in some lectures, centration is probably one thing which is important. And secondly, in our experience, what limits the effect of hyperopic corrections now, it's not really the laser, it's the way the cornea heals. And if you do epithelial monitoring, you may see that after the surgery, there's, like in the periphery where the ablation is deep, sometimes 10, 20 micron increase in the epithelial layer locally, which makes the cornea maybe too prolate in some cases. So again, the future would be, can you anticipate this, control for that, so you can stabilize the cornea? And maybe in hyperopia, additive techniques will also be increasing in popularity to overcome these issues.
Wonderful. Well, that concludes our section.